So thanks everyone for coming to this third edition of the HiRO Knowledge Translation Rounds. I guess I'll start off by thanking Amanda for helping to organize this, and also Andrew for advice on planning and helping us connect with some of the speakers tonight. So for anyone missing any of the previous editions, I'll just kind of start by kind of outlining what we're planning to do here. Obviously, HiRO, the HiRO network has has numerous research studies, which we're obviously incredibly lucky to benefit from the enrollment of patients in those research studies, and also to support the network of researchers that use that data to produce high quality research in the field of inherited heart disease. The idea of this evening is that we'll discuss a couple of papers, actually two of many publications from the last 12 months that have come from patients and researchers connected to the network, and trying to specifically focus on how we can integrate those findings into our practice. And then right at the end, we'll maybe also hear from some other members of the network about some potential future projects. So I'll hand over now to Simon to talk a little bit about housekeeping.
Thanks, David. So we've got three speakers this evening. We're really grateful for all of you for attending. We're going to give you about 12 minutes or so each to speak, and then we'll have around 5 minutes for questions at the end of each presentation. Just please keep your microphones muted. That would be really helpful. Question-wise, you can either pose your question in the chat. If you'd like to ask your question directly, you can do that, but just raise your hand, and then David and I can then field the questions as they come in. We're grateful for you being here, and just encourage you to participate and to ask questions. So with that, I'm going to introduce our first speaker. Borna Nadiri. So Borna is a third-year medical student at UBC. He sent me his little blurb, and he said he began his journey with the Hearts in Rhythm organization during his undergraduate studies and has continued to build on this foundation throughout his medical school. His research focuses on inherited arrhythmias and their clinical implications, and he aims to improve early detection and patient outcomes. So he's going to speak to us regarding his recent publication regarding the diagnostic utility of Holter monitoring in CPVT. Borna, great to have you here, and over to you.
All right, thanks everyone. Thanks so much for letting me present today. So my name is Borna, and I'm one of the medical students here at UBC. So today I'll be talking about a recent publication of mine with Dr. Kron, which is the topic is diagnostic utility of Holter monitoring in CPVT. All right. So just a bit of background. So CPVT is an adrenergic-induced arrhythmia. So it means that during sudden adrenergic stimuli, so this could be anything like exercise, emotional stress, or even excitement, patients can develop polymorphic or bidirectional VTs. And these arrhythmias may present with palpitation, syncope, or can even progress to sudden cardiac arrest or sudden cardiac death. So the underlying etiology is primarily related to calcium overload, and most commonly is associated with RYR2 mutations, which roughly account for around 60% of cases. There are other variants as well, but the focus of this paper would just be on the RYR2 variant. In CPVT, patients typically have a structurally normal heart, and their resting ECG is also normal as well. So for that reason, we do rely on stress testing as a mainstay of diagnosis to help provoke these adrenergic stimuli and then hence see the VTs that are very essential for diagnosis. So in terms of the rationale and the clinical question, so when patients typically come with symptoms of arrhythmias, one of the first tests that clinicians often order is a 24-hour Holter monitor as part of the workup. Also, frequent ambient PVCs can hint at an inherited arrhythmia or other possible cardiomyopathies. But the utility of this form of diagnostic perspective is largely unknown in the CPVT population. So for that reason, our objective in this paper was to compare the PVC characteristics in CPVT patients against those in healthy controls, and to really try to see if we could elicit a distinct Holter monitor phenotype that's associated with this population. All right, so in terms of the population inclusion criteria, well, this was a retrospective cohort study, and we were using off therapy 24-hour Holter monitors from the National HiRO Registry. Um, in terms of the healthy controls, these were essentially family members that underwent genetic testing and cardiac screening, and they were deemed as healthy. And for the CPVT patients, we only included the pathogenic and the likely pathogenic RYR2 variants, and we did this to make sure that there's a strong correlation between the phenotypic and the genotypic presentation of them. We also excluded any VUS genes, and for the CPD patient to be included, we made sure that they also meet the clinical diagnostic criteria of having a VT that was either polymorphic or bidirectional. All right, so in terms of the analysis, so there are two approaches that we took. Approach A is comparing the total PVC count during the entire 24-hour Holter monitoring period between the healthy controls and the CPVT patients. And for approach B, because PVCs in CPVT are primarily adrenergically induced, our goal was to separate these PVCs into high and low adrenergic periods. So to accomplish this, we drew on Edwards' method, which defines heart rate zones based on how an individual's current ambient heart rate compares to their maximal recorded heart rate. So we started by taking each patient's highest recorded heart rate on the monitor and define it as 100%. Then for each 1% increment from 1% to 100%, we use that percentage of the maximum heart rate as a threshold to separate the PVCs. So whenever a PVC occurred at a heart rate above this threshold, we labeled it as adrenergic. Otherwise, it was just labeled as non-adrenergic. And then to identify the maximum heart rate percentage that best distinguish these CPVT-induced PVCs, we performed an RSC curve for each of these percentages. And then we also constructed a confusion matrix to then assess how accurately this cutoff could discriminate between CPVT patients and healthy controls. In terms of the results, just a population comparison between the two cohorts, we started with 54 healthy individuals, and then we ended up with 34. And then likewise for CPVT patients, we started from 40 patients that we screened through, and we ended up with 13. I know these numbers are very low, but we had to make sure that they were off therapy, and then the 24-hour Holter monitor was actually available, which was a bit of a struggle. But nevertheless, we can actually see that the two cohorts are very similarly matched in terms of the median age, the gender, the maximum heart rate, mean heart rate, and the QRS complexes that they had. Now, for approach A, so in here we were comparing the total PVC count between the two groups, and we realized that when comparing the total PVC count during the entire 24-hour Holter monitor, CPD patient had significantly higher PVC counts, but the counts themselves were actually very low, and they're not that significant. The PVC burden was also statistically different between the groups, but they remained generally low, and they were still within population norms for both age and sex. So this kind of perhaps suggests that high ambient PVCs are not a typical finding in CPVT. Something that was interesting was that the number of QRS complexes was also remained non-significant between the two, and this is actually a pretty good finding because it means that there's no sinus node dysfunction, which is a recognized feature in CPVT. So overall, this suggests that ambient PVCs are not a distinguishing feature of CPVT, and relying simply on the total number of PVCs or the burden is not really a specific marker for diagnosis. Total PVC count during the monitoring period can also be influenced by the patient's level of activity, but also by other arrhythmia-inducing conditions other than CPVT. So it's important that we proceed with those two markers with a bit of caution. Now, in terms of approach B, now going back to the slide, so our goal was to find a threshold that would allow us to separate these PVCs from adrenergic to non-adrenergic. And when we did the RSC calculations, we actually found that 76% of the maximum heart rate was the best threshold to differentiate these two PVCs, and it actually allowed us to, with highest accuracy and specificity, to discriminate between CPVT and healthy patients. And this 76% actually equates to above moderate level of activity if we refer back to Edwards' method of heart rate zones. So this 76% threshold, as I mentioned, had the highest diagnostic value, and it equates to around this sensitivity of 70 70% and specificity of 94%. With this categorization, we only saw a difference in PVC during adrenergic periods and not during the non-adrenergic periods that we had categorized, which kind of aligns with our current understanding of CPVT and this disease, which is generally a disease that's unmasked by adrenergic stimuli, and it's absent at rest, which is why the ECGs, baseline ECGs, are negative. Interestingly, with this approach, a high PVC count during low adrenergic states may actually argue against CPVT and may push clinicians to think of other mechanisms that could be causing these PVC counts. In our population, the 76% heart rate actually translates to a heart rate of approximately 106 beats per minute, which roughly aligns with our current literature, where we generally expect to see CPVT-specific ectopic activity, which on a stress test is around like 110 to 120. So it's very close. In terms of the clinical applications, so by no means is this approach supposed to replace the ongoing stress test, but rather as an adjunct to it when we're just clinically unsure and the phenotype is a bit ambiguous. Another clinical pearl of this or application of it is that in some situations, performing a stress test is not feasible. So we have children that are too young and they can't really follow the instructions safely, or in situations of a major cardiac event, many patients are unable to exercise due to neurological physical deficit. So this could be a good adjunct to all of that. And this approach to Holter monitoring may also have a role in monitoring the patient's therapeutic responses as well. So, sorry about that. So you can actually you can think of the stress test as a single capture or a single measure of where we evaluate cardiac function. So whereas the Holter monitor captures like a broader spectrum of the cardiac activity, which then reflects like the patient's typical level of exertion and stress that they endured throughout the whole day. So this can ultimately allow clinicians to better capture patients of ADLs and IDL profile, and then offer personalized treatments to better manage their CPVT symptoms. On a similar tangent, with this approach, we can assess the patient's baseline risk of arrhythmia in the setting of their daily activities, and subsequently, we can actually consider maybe like less aggressive management, even if the stress test, which is a very structured and highly stressful test, may suggest a higher risk of arrhythmias. So overall, CPVT patients have a very low overall burden of PVC, and these PVC counts cannot really be relied on as they are. We have to kind of take the whole clinical context into place, and we should really be looking at the relationship between the PVC count and the heart rate as a useful approach to kind of see if they're really distributed within those adrenergic periods to help with the diagnosis of CPVT. Okay, thank you so much for listening, and I'll be happy to take any questions.
Thank you so much. That was a really great presentation and a really interesting paper. I really enjoyed reading it. What I'll do is maybe start off with a couple of questions, and then I think Simon has some additional questions potentially. And if there are any questions from the chat, then Simon will field those. So I guess one thing I just wanted to really make sure I understood from the paper was in terms of the sensitivity and specificity that were given. If I understand this correctly, what this paper is saying is that if I do a Holter in a patient that I suspect may have CPVT, and they have any PVCs when their heart rate is above 76% of their maximum, then that is the circumstance under which the sensitivity and specificities for the diagnosis of CPVT apply. That's correct, is it?
Yeah, pretty much.
Okay.
Yes.
Wonderful, good. My next question, I guess, was I was kind of curious to know, obviously when we have Holter data, that Holter monitor will often come with an activity diary. And I wondered if you had any idea about the kinds of activities that these patients were doing. I mean, obviously there are things like the burst protocol, which we think have greater sensitivity for diagnosing CPVT. I wondered if maybe we had any idea if the people that in the CPVT population were, for example, doing similar kinds of sudden onset high intensity activity, or whether what kinds of things people were doing, if that
Yeah.
could have had some impact on the results that you found.
Definitely that would have actually been a very interesting thing to see. It did cross my mind early on, but the problem was just with data availability and having actually access to those diaries. Um, so for this, we just primarily went based on the 24-hour summary sheets that the author generated. But yeah, that's something that we can definitely explore to see. Maybe there's some pattern as to both the time and the type of activities that maybe can induce these PVCs.
Mm, okay. And I guess my other question was slightly more technical, I suppose. I noticed that the data for this study comes from only from BC and the London Health Sciences Centre. And I wondered, is that because the type of data that you needed in order to do the analysis was really only available from some additional kind of offline raw data that wasn't available from the other centres that contribute to the HiRO
Yeah.
network?
Yeah. Yeah, well, we actually try to get data from all the HiRO sites, but at the end of the day, it just really depended on what was available. And the ones that we had the Holter monitor, the 24-hour Holter monitor, but they're also off therapy, and we had access to the 24-hour summary sheets. Those were only available from the three sites.
Okay.
Yeah,
Okay. So it wasn't so much that the data had to be in a raw
yeah,
form, like you
yeah,
didn't have to have large kind of files
yeah,
transferred from. Okay.
yeah.
Yeah,
Okay.
if I could just comment, it's one of these circular things where there hasn't been a previous recognized indication for Holter in these patients because our primary focus is on exercise.
Yeah.
And so, but it started off with somebody saying, "Can you please review this patient for CPVT?" And they had 5% PVCs. And I said, "No way." And then looked at the literature and there's nothing out there. And then said, "We should look at this." And then looked at a few local patients and said, "Well, the burdens are very low." And then I was discouraged by the fact that we could only find so few patients who had ever had a Holter across HiRO, across a fairly broad spectrum. Although CPVT is a relatively newcomer to our
Mm.
enrollment process. So I think this supports the idea that it may be a useful surveillance test, in part also to see how much they're taking their beta blocker.
Borna, can I ask you a question if that's okay?
Yes, of course. Yeah.
First of all, fantastic presentation. Like third year med student, that's a fantastic presentation. So well done. Again, great paper. Did you have a look at how many kind of adrenergic states these patients had? So how many times were their heart rates going into that kind of range where you might see more PVCs? And then on that same line, looking forward, if you were to think about incorporating this in some sort of clinical assessment of patients, do you think there's utility in having a longer period of monitoring so that you get more of these events?
Yeah. So to answer your first question, so what I did was I included even the hours that the patients were above this specific threshold, even if they didn't have any PVCs, I still include that in the calculations. So I included all the heart rates above it. Um, and so based on that, I guess it kind of captures all of it. Sometimes the patient didn't have any, sometimes they did, but I would say most of the times what I found was if the heart rate was above this threshold, 80% of the time there was some PVC that was happening. And it could be like 10 PVCs or even one. There's rarely any that were zero. Now the second thing was in terms of like the clinical applications of this. Well, it also kind of circles back as to the patient's level of activity. So we do want to make sure that we capture their daily function. Essentially, this is what the whole purpose of the Holter monitoring is. We can extend it, but if that really adds any additional value, I'm not sure because ideally in that 24 hours when they go home, they kind of continue with the day, they sleep, the next day we wake up. That should capture the routine. Unless maybe if a patient, maybe for that day, they kind of deviate from the routine, maybe they're like more exercising more or they're doing something else, then maybe doing a longer period would be better. But nevertheless, I think that threshold would still stay and those similar applications, we can still apply them.
Yeah, that's a good answer. Excellent, thank you. David, do I hand back to you if there's there's one question Kirsty's put a question in the chat very quickly. Many of the patients with RYR2 with VUS designation, did we lose numbers with a focus on likely pathogenic or pathogenic? Is there going to be a follow-up to correlate on treatment halter with stress data?
Yeah, so to answer the first one, yeah, we did lose a lot of patients that were VUS and they didn't get to that likely pathogen, the pathogenic designation. And the only reason we stuck to likely pathogen pathogenic is just because we wanted to make sure that there's a good correlation between the phenotypic presentation and the genotypic presentation, because as you guys know, CPVT is very heterozygous, so there's a spectrum of presentation. And now the second one, is there going to be a follow-up to correlate on treatment halter with stress data? Ideally, yes, this could be definitely be a next step, but we didn't explore that in this paper.
Great. Thank you.